Okay, thanks very much for coming back. And also thanks for being nice to Oliver. I mentioned that you should be nice to him since he was my boss. It wasn't anything to do with the quality of the lecture, it was just you were being kind to him. So here he is back for more, and this time we're going to learn about, say, possible advances in treatment of psychosis.
So, thank you very much. I obviously didn't do a good enough job in my first lecture, so I have to do a second lecture to try and redeem myself. So, changing topic here, I'm talking now about treatments. You know my disclosures. This is the learning objectives. So, I'm going to be talking much more about other people's data now, talking a bit about what we already have and using it better. Talking about what has just arrived, and I've already told you that we have not had very many drugs licensed, so spoiler alert, there's nothing too exciting. And then what's coming, as Marta asked me to talk about what might be round the corner. It's in drug development. So of course this is very much my own perspective on things, and I am going to be talking about pharmacological treatments, not going to be talking about other treatments as well. Because I've only been, I've got limited time, so I've even had to prune some of the pharmacological treatment stuff as well. So, course of schizophrenia. We know that it begins with cognitive and negative symptoms, which tend to continue throughout the course of the illness, and then there's psychotic symptoms that come and go, and are what usually lead to someone presenting to their doctor. This is taken from a review that clearly the last author was a bit of a fool, because he was talking about outcomes in schizophrenia, but he didn't talk about the most important one at all, which is mortality. And this is, I think, one of the areas that has been a big advance in recent years, is that we have finally, as a field, woken up to mortality in our patients and started to think about it. And now, in the last decade, there have been lots of studies looking at mortality in people with schizophrenia and other mental illnesses, and showing that time and again that our patients die earlier than you would expect. This is a meta-analysis published a few years ago that summarized them all and shows that on average people with schizophrenia die 15 years earlier than you would expect for their age and gender, etc. So this really is the most important outcome of all. And of course, a big question then is, well, does our treatment make any difference? And again, this is something where in the last few years, finally, in the last, I think, 3 or 4 years, we've woken up to trying to test this. And this is largely thanks to people in Scandinavia, where they have these excellent databases that they can look at it. So I know you've just had a coffee break, so I want to wake you up with a question again and use our sophisticated Q&A system. So the question for you is, in people with schizophrenia, relative to no antipsychotic treatment, is antipsychotic treatment associated with 10% higher mortality, 30% higher mortality, 50% lower mortality, no difference in mortality? So this is your question. Please put your hands up if you think 1 is the right answer. Antipsychotic treatment associated with higher mortality at 10%, 1. What about 2, 30% higher mortality? 2, 3, 4, 5, 6. What about 3, 50% lower mortality? 2, 3, 4, 5, 6. There's a few more, 7. No difference in mortality. So most of people, I think, would say no difference, but then perhaps a little more for lower and a few for higher at 30%. Interesting. So where has this been tested? Well, Finland is the country that has started this all off, and Jari Tahonen and Heidi Tapala in particular. And the advantage they have in Finland and other Scandinavian countries is that they have these databases that cover the whole population, because they have registries of everyone who's born there and their hospital admissions and treatments. So Heidi looked at this data. It's naturalistic data, and this is, of course, what you need, as good as it's going to get when you're looking at long-term outcomes like mortality. And she looked at everyone with schizophrenia in a defined period in Finland. So over 60,000 patients who'd had at least one admission with schizophrenia during this time period, and looked at what happened to them in terms of mortality over the next 14 years. And the interesting thing there is that they then looked at whether they were more likely to die when they were taking an antipsychotic or when they were not taking an antipsychotic. So reflecting the fact that people don't take their antipsychotic continuously. Sometimes they come off it through their own decisions. Sometimes their doctor stops it. But just looking at whether they were more likely to die during a period of treatment versus no treatment. And here are the data. So this is the survival probability. It starts at 1 because that's at the beginning when they are alive. And here you can see over time what happens if you are spending more time on an antipsychotic treatment in black, in the grey colour at the top, or if you are not on an antipsychotic treatment in black. So you can see that the curves diverge, and the people that were not on antipsychotic treatment were more likely to die than those on an antipsychotic. So those of you that said 50% lower, you're right, because actually if you look at the odds ratios, this is actually the raw data, but the odds ratios, all-cause mortality, the hazard ratio if you're on an antipsychotic was 0.48, so about 50% reduction compared to not being on an antipsychotic. And you can see that in the raw data as well. Very interestingly, patients on clozapine had the lowest risk of dying, which is interesting, of course, because this is the drug that we associate with lots of side effects and risk of agranulocytosis. Now, you may wonder what underlies this. And risk of suicide is markedly reduced in those people taking treatment. So that's, again, about a 50% lower risk. So potentially some of that is associated with lower suicide rate. But then you might think, well, perhaps the treatment is helping reduce the risk of suicide, but that comes at a cost of side effects, and particularly cardiac side effects, which we know is the cardiovascular disease is the leading cause of mortality in our patients, higher than suicide, and is increased relative to healthy people. So what happens to the risk of cardiac death? Well, that is also lower in people taking antipsychotics, which I think is one of the most important findings in the last few years for our patients, because it's telling us that the treatments overall are not associated with higher mortality, but actually with lower mortality, and that includes the main physical causes of early death. But of course, it's naturalistic data, so you have to think, well, is there something different about people that take antipsychotics regularly versus those that don't? Now, some of the outcomes that you can look at and that they've looked at in these databases, you can control for that because the patients can be their own control. But that's difficult with death because you can't then re-enroll them in the study after they've died. They don't go and take antipsychotic again. But what they have done is something very clever, which is look at the relationship between taking an antipsychotic and whether they are more likely or less likely to take treatment for physical health problems, particularly cardiac medicines. So this is a study that again used the Finnish cohort, and what they did, which I think is clever but is a little complicated, is they looked at treatments with the antipsychotic. So you can see that at the top. In this case, the patient started olanzapine, took that for a period of time, then they stopped any antipsychotic, then they went on to clozapine, then they stopped. Now, all that time, they were taking a statin, and they stopped their statin at that point, and that is what they're using as the outcome measure. It's not starting the drug, because, of course, that might be confounded. You might start your olanzapine and your statin when you're admitted to hospital, so that wouldn't be telling you about whether you're more or less likely to take a statin, whether you're on antipsychotic treatment. Instead, they're looking at whether you're more or less likely to remain on your treatment, your statin or your other cardiovascular treatment, depending on whether you're taking an antipsychotic. So in this case, the person wasn't taking an antipsychotic, they stopped their statin, and that would be an increased risk of stopping your statin when you're not taking treatment. In this case, another patient on clozapine, then they're on polypharmacy, then they go on to risperidone, and they're on risperidone, and they're taking a statin for this period of time. They stop the statin when they're on risperidone, and that's an example where they stopped the statin when they were taking an antipsychotic. So that time, it's increased risk when they're taking an antipsychotic. So does that make sense? No, no. I'm not sure how I can explain it anymore, and perhaps we can talk about it in the coffee break. But it's a complicated design, but what I think is neat is that they're looking at discontinuation of the cardiac treatment. So this is the data. So this is the different antipsychotics. This is your hazard ratio of stopping a statin, depending on whether you're taking your antipsychotic or not. Anything below 1 means you're less likely to stop it if you're taking the antipsychotic. And what you can probably just about see from the back, but I can point out, is that across all the different antipsychotics, actually the hazard ratio is if anything lower, but it's significantly lower for a number of these drugs here. Some of the others, it's lower but not significant. This is partly because of a power issue. Some of these drugs didn't have very much exposure at all. This is the number of patient years of follow-up they had. And you also see this with some this is first-generation drugs. This is also true for some second-generation drugs as well, like clozapine. In this case, about 60% lower risk of stopping your statin if you're taking clozapine, olanzapine about 60% as well, aripiprazole about 50%. So I don't think the individual drugs really matter. The message is that there's lower risk across a range of treatments for statins being stopped, but also other treatments like antihypertensives. So this doesn't prove, of course, that antipsychotics are in some way helping people take their statin or their antihypertensive. What it might point to, though, is that if people are well or better, then they are better able to engage in other treatments as well. That's a hypothesis. It doesn't prove that. These are naturalistic data, but it's certainly telling us that our drugs are not making things worse. So that, I think, is, if you remember one thing from this session, I think that is the most important thing, because I think that's the most important thing that's come out in terms of treatment. But I want to talk about something else now, which is atypical antipsychotics. So a question for you again. Which of the following are atypical antipsychotics? So choice 1 is olanzapine, haloperidol, and risperidone. Choice 2 is amisulpride, olanzapine, and risperidone. 3 is none of them, and 4 is all of them. So if you think 1 is the right answer, put your hand up now. If you think 2 is the right answer, put your hand up now. Oh, about 20, yep. If you think, if you think none of them is the right answer, 2 or 3, 4. If you think all of them is the right answer, 1 person, yep. And I've learned, of course, that I need to put don't care on there as well, but because not everyone answered. So most of you said number 2, amisulpride, olanzapine, and risperidone. So this is an example where the majority is wrong, I think. And I'll tell you why. Because we looked at what are the definitions of atypical and typical antipsychotic. And this actually goes back to a paper that Jeff Lieberman wrote in the 90s. And the 3 criteria were higher prolactin, effect on prolactin, so higher prolactin in first-generation antipsychotics, lower in second. Higher risk of extrapyramidal with first-generation or typical, lower with atypical. And then efficacy. And here is a heat map that shows the risk of these things, grouped by whether they are considered to be typical or atypical. So the typicals at the bottom, atypicals at the top. This has just been published. And the darker color means the higher likelihood of this. Now, if there was really a grouping into typicals down the bottom and atypicals at the top, you should see uniform colors within the typical and a different color pattern in the atypical, and you just don't see that. The only drug that really seems to meet these criteria is this one here, which is clozapine. It shows light colors across the board. And of course, that's because that's what was used as the prototype. But in practice, how we actually classify them doesn't follow that at all. So I think we should just get rid of a classification term like typical, atypical. It implies something that just doesn't exist in reality. In fact, the drugs all have pros and cons in terms of these efficacy and extrapyramidal side effects and prolactin effects. And we need to think about the drugs individually rather than in terms of classification. Does this matter? Well, it does matter because guidelines and research often does this. And we talk about, we analyze the atypicals and separately from the typicals. Well, that's a bit of nonsense when you think that there's so much variation between these drugs. So that's my rant over. I think we just throw out this sort of classification. Now, what else I think is new about existing drugs? Well, something that's interesting in terms of long-acting injectables, and this is probably where we've had the most advances in terms of existing drugs, is that we're now getting drugs that really can be used very infrequently. So this is the table of depot drugs, drugs available as depots from the Maudsley guidelines. But now we have 2 new drugs that are just coming. So we've got aripiprazole 1 monthly already, but Otsuka and Lundbeck have just produced a 2-monthly version, which is about to be released. And of course, we also have paliperidone now available as a 6th monthly injection called biannually. Does anyone get what they've done there? Biannual injectable. I don't know what was going on with Otsuka and Lundbeck to come up with Asymptify. I have absolutely no idea how that's supposed to imply anything. But, and as I said, I was working for Lundbeck, but they didn't ask me about the name of this when they were coming up with it. But, I think Janssen have done quite a nice job with this one. So this is really interesting because this gives us a partial agonist that we could potentially use only 6 times a year, and a D2 blocker that a patient could have just twice a year. So this is a real, I think, game changer for those patients that really don't engage, or those patients that are very well and don't want to keep coming to a clinic for an injection every 2 weeks or every 4 weeks, and for those people that don't want to have injection site abscesses and all that rigmarole. So it's not going to suit everyone, but I think these are real advances. Now, we have to think about whether it's possible to use these long-acting drugs. What happens to the levels over time? Because there is a risk you have to give more of the drug for it to last. But Janssen have looked at the plasma levels of paliperidone and compared 6-monthly paliperidone to 3-monthly. So 3-monthly is in blue and 6-monthly is in red at different doses. So what you do see is that you get a slightly higher peak of the 6 monthly, but you also get a slightly lower trough. So that could be a concern because you've got a period of time down here towards the end of the last month or two where the levels of the 6 monthly are below or approaching low levels with the 3 monthly. Does that matter though? Well, they've looked at relapse risk and compared the 3 monthly and 6 monthly, and here's the study. And the 6 monthly is in red and the 3 monthly is in blue. And you can basically see that the relapse rates were all very low and similar. So it doesn't seem that you get an increased risk of relapse with having the drug given less frequently. Of course, this study is just one study, and I think reality will come when it's used in clinical practice and we start to see, what happens in the cut and thrust of the clinic. But it doesn't seem that our patients are at increased risk by going to less frequent injections. So that's about as good as it gets in terms of our, things that have happened with our current treatments that are available or just about to become available. And of course, there's a big elephant in the room, and that is treatment resistance, which is, I think, an area where, again, we're beginning to wake up to the fact that we haven't been doing enough about it. And treatment resistance is something that I've been looking at and been quite interested over the last few years. I actually wrote a paper about how to identify treatment resistance, and you might think, well, that the author list is almost as long as the paper, and perhaps the paper wasn't worth it, because we came up with the conclusion that inadequate response to adequate treatment with at least 2 different antipsychotics each for 6 weeks is how you should define treatment resistance. But the reason that was worthwhile is because actually a lot of the clinical trials that have been used as the evidence base for treatment resistance have conflated patients that didn't take treatment or were not tolerating treatment with treatment resistance. So this was to try and get more rigorous approaches to studying it. But what can we do in practice? Well, this is a case of using what we already have better, because we know that clozapine works, particularly if you look at the more rigorous trials where you see the bigger effect sizes. But I think the big problem is that we don't recognize it. We often under-report it. So I'm going to ask you a question. What is the prevalence of treatment resistance in outpatient clinics? Choices are 1, 15%, 2, 55%, 3, 33%, and 4, 25%. So again, use your sophisticated Q&A system. If you think 1 is the right answer, put your hands up.
What outpatient clinic are we talking about?
Just a general outpatient clinic. Actually, I'm going to give you data from South London, which represents the world as far as we think from Maudsley perspective. But yeah, actually, there have been studies in other settings as well. So just a general outpatient clinic. So I'm not talking about looking at treatment resistance in long-stay wards, in rehabilitation services. I'm talking about your average community team with people that are out of hospital, stable, generally pretty stable. So one is 15%. Robin said that. 2 is 55%. Anyone? Well, a couple of hands. 4 or 5 hands. 3 is 33%. That's about 5 or 6, 7 hands. 4 is 25%. More hands. I'd say probably more. There's a tie between 33 and 25%. Well, the data from South London are 56%. So 55% was the closest answer. So this is a study that we did looking at...
but my patients do much better.
Your patients do better than mine.
15%.
Okay. I did say just your average clinic. Yours is an exceptional clinic. And I think that's maybe that's part of the issue, that we often think that our patients are doing better than perhaps they are. And when you go and look and actually look at the patients, you see that there's much more treatment resistance than you think. Now, 33%, that's probably what the prevalence is amongst the entire population of people with schizophrenia from the epidemiological studies. But of course, the people that do very well get discharged from our outpatient clinics. So over time, we enrich our clinics for people that are not doing so well. So we should actually be thinking potentially of having 50, 60% of our patients on clozapine. That's what the guidelines say. And we used the guideline criteria to define treatment resistance when we did this study. But actually, when we looked, less than half of the patients with treatment resistance had ever tried clozapine. So there's 25% of all our patients in community outpatient clinics who had never tried clozapine and should have been given the opportunity to try it, based on the guidelines. So I think I'm holding up my hands here in terms of South London anyway, and my hospital trust, that we are not doing very well with what we've got. We need to do better. And it actually is a bit worse than that. So even amongst the people who had started clozapine, when we looked at those people, so these are those that got onto the drug, on average, it had taken 4 years from the point at which they met criteria for treatment resistance for them to start it. And this is in the Maudsley, and of course we like to think that we are much better than everyone else, but clearly we're not. So something's going wrong here, and there are lots of factors that contribute to it, but you might well say, well, does it matter? Does it matter having a long delay? And the last few years, there have been a few studies that have looked at this, and it's just been meta-analyzed. So anything on this side of 0 means that you had a poorer response if you started clozapine after a longer delay. Anything on this side means you had a better response. So overall, your chances of responding to clozapine when you got to it were 70% lower if you'd had a longer illness duration. Now, that's not the case in all of these studies, but these are all relatively small studies because people have only started to look at them, but it does seem to, when you put it all together, it's pretty clear. So this is telling us that we need to get on with things. We shouldn't be hanging around. Now, of course, there are issues with duration of illness. There's something called lead time bias, and we can discuss that, which complicates interpreting these sorts of data. But I think from a clinical perspective, all things being equal, this tells us that we should get on with clozapine, because the chances of someone responding is better if they've had a shorter illness. How to do that in practice? Well, as I said, I'm holding up my hands about our trust. We're not doing it particularly well. So one thing we did was set up a service to try and help that. And I think it does take something like that, because guidelines, even though I've spent time writing them, don't really seem to make a difference to some of these things. We've had the NICE guidelines in the UK for over 20 years, and I still showed you that the delay in starting clozapine was about 4 years in our trust. So clearly guidelines don't work. And I think it's not fair to say to busy clinicians, you need to read the guidelines and get on with things, because clearly it's not as simple as that. There are barriers, and you need to help with that. So we set up this model, the TREAT model, to try and help with it. And I'm just going to share with you a little bit of data from our outcomes. And this is naturalistic data. So this is, firstly, people told me initially, you can't start clozapine in the community. It's not safe. And that's one of the findings we had, was actually that almost all the patients, 95% plus, were admitted to start clozapine in my trust. And there's actually a survey across the UK, and a large proportion of psychiatrists thought that you had to be admitted to start clozapine. Now, I had a lot of my colleagues in South London and Maudsley telling me, you can't start clozapine in the community, it's dangerous, you need to be in a hospital and they need to be monitored closely. But that's not the case. We know in other parts of the world people do it. It just needs some system to do it. So this is part of what we did. And we found that actually you could start clozapine safely. We had no problems, and no significant problems, I should say, no lasting or serious problems. And it made a difference. I'm not going to show you the symptom changes, but I want to show you some of the hardest data. So this is hospital bed days. In the year before clozapine, in the first cohort we put it through, and then in the year after. So you can see the vast majority in the year after had absolutely no hospital admissions. There are one or two that went from 0 to being admitted. So clozapine doesn't work for everyone, and I'm not saying that at all. But particularly the ones who had been more unwell, had been in hospital longer before they started clozapine. And remember, they were in hospital at some point, but not in hospital when we started clozapine, which is another story. You've got to wonder why they didn't start it when they were in hospital, when there was a good opportunity, but they all started in the community. But the vast majority did well in terms of hospital admissions. But my colleagues also said to me, yes, well, you might do that, but you're going to end up having to do much more outpatient work with them, and there'll be more resources required for that. But that's not the case either. So this is the number of outpatient contacts on average in the year before clozapine, and then in the year after. So again, a significant reduction, about half as many, because they were better. And this also factors in that sometimes they got better and were then able to engage with their psychological treatment that they'd never had before because they couldn't engage with it. So sometimes they were actually having a lot more outpatient contacts because they were having CBT or occupational therapy. But overall, they didn't need as many appointments with their psychiatrist or their psychiatric nurse. So you can do it, and it can make a difference. And it can save money as well. We calculated about £800 per patient per year. So that's about using what we've got better. I want to spend the last part of my talk talking about what's on the horizon to give you some idea of why things might be, what might be coming. And if you'd asked me to talk last year, I think it would have been a bit depressing. In fact, the last few years, because there hasn't been very much. But I think this year is very exciting because we are on the cusp of some really interesting and exciting new treatments. And this is a review we wrote looking at some of them. And here's the receptor binding profiles of drugs that we've already got, aripiprazole, clozapine, etc. And then these are the drugs that are in development. And what this really I want to point out is that they are quite different. These are not, this is where D2 is. And you can see all the old drugs blocking D2 receptors. But some of these new drugs do not act on D2 receptors at all. Now, this is why I think it's so exciting, because we are on the cusp of potentially a different mechanism of action for the first time in 60 years. So I'm going to talk particularly about these two in the first bit of this section, which is this drug CEP and this drug xanolamine. And then I'm going to talk about a glutamate drug if I've got time as well. So starting with CEP. Has anyone heard of this drug? Just a few of you. So this is a traceamine receptor agonist. And if you haven't heard of CEP, you probably won't have heard of traceamine receptors. They were only cloned about 20 years ago. And they are highly expressed in monoaminergic neurons, including the dopamine neuron. And activating them reduces the firing of the receptor. So this is potentially a way of tuning down that overactive dopamine system that I was talking about before the break. Because by activating the receptor, you are reducing the firing. They do some other things as well. Now, we tested this actually in a mouse model of the dopamine overactivity that we see in patients. So this study, we gave mice subchronic ketamine, which releases dopamine, and after you've washed them out of ketamine, that dopamine overactivity persists. So we're talking about ketamine this morning as a treatment for depression. Well, I'd like to tell you one thing that it does do is cause dopamine changes. So maybe that's part of its mechanism. So they've been washed out of their ketamine, but they still have this elevation in dopamine activity. This is synthesis capacity, the same measure that we use in patients. So this is mice treated with ketamine. This is our model of that dopamine overactivity. What happens when you give a TAR1 agonist? Well, here are the data. And Michelle did this. So this is in red, the ketamine-treated mice. Again, you get that overactivity in the dopamine system compared to controls. But if you have treated them with a TAR1 agonist, it's back at control levels. So that's really exciting. You can imagine my excitement. Here we've got something that does normalize the dopamine abnormality. Now, it has been tested in the clinic. This is being developed by Synovian. And they did a phase 2 trial, which was published recently. And here are the data from it. So this is the change in the PANSS positive score. Gray is the placebo group. Green is the CEP group, the TAR1 agonist group. And you can see over the course of the 4-week trial, there is a separation. And the patients treated with the TAR1 agonist showed an improvement, significant improvement over placebo. So that's exciting, interesting. It's the first proof that this might actually work in clinic. They also looked at negative symptoms. And there I think you didn't see such a dramatic effect. But again, separation by 4 weeks. So potentially a benefit for negative symptoms as well. But I think there is one little caveat that I want to point out, which is that the placebo response is tailing off, and it's relatively modest placebo response compared to other recent trials with antipsychotics. Not compared to older studies, but compared to more recent ones. So I think this is encouraging, but I think we need to see the phase 3 trials before we really know this is going to work. So those phase 3 trials are currently in progress. They're going to read out later this year. So look out for this. If these are positive, then we will have a whole new approach potentially to treating psychosis. So that's the TAR1 mechanism. What about other mechanisms? Well, another approach is again upstream, is to target muscarinic receptors, which regulate, some of them regulate dopamine neurons. And a drug that has been developed for this is a combination of xanomeline and trospium. And the reason that they have to have this combination is shown by this study. So this was a study published many years ago in the American Journal of Psychiatry, and it was just using xanomeline in patients with schizophrenia. And they showed a positive benefit for the drug compared to placebo over the course of 3.5 weeks. But lots of side effects. So this drug was developed by Lilly, and Lilly actually were also testing it for other indications, and they didn't proceed with it because it was not very well tolerated. So here are the rates of nausea, vomiting, and other gastrointestinal problems. And you can see that it's a small study, only 10 per group. 7 out of the 10 patients got nausea and vomiting. So these are really high rates. So they didn't continue with this drug, and that's, of course, because muscarinic agonists, muscarinic receptors are in the GI tract, and muscarinic agonists are causing these problems. But what's happened more recently, and what's breathed new life into this, is that the combination of this drug with trospium, which blocks peripheral muscarinic receptors, means that you have the potential to block the side effects. And trospium doesn't cross the blood-brain barrier very well, so then you've got a way of blocking the peripheral effects, but allowing the central effects. Now, this has been tested in a phase 2 trial. Here are the data. So again, this is the improvement in the PANSS symptom ratings. This is the placebo in black, and then this combination in blue. This was published in the New England Journal a couple of years ago, and this is the first data that shows, again, a benefit for this combination, this drug, by 5 weeks. Again, this is interesting because the placebo response is relatively small. So you've got to be a little bit cautious. Now, this may be like the Synovian study because this is a quite small phase 2 trial. But what we already know from the company website is the data from the phase 3 trials. And here you see a much more robust placebo response, more typical of what we see these days in trials, but you're still seeing separation. 20 points improvement in the PANSS total in the group treated with the combination of xanomeline and trospium. This is a really healthy improvement. Effect size is 0.6. And they've also seen that in their second phase 2 trial. So this, I think, is really exciting. And they, as I understand it, are now going to the FDA for licensing later this year. So this is, pending what the FDA say, something that may well come to your clinics next year. Now that was total symptoms. They saw improvement on positive symptoms as well, but less improvement in the negative symptoms. Potentially there was an improvement, but if you look at the placebo group, the negative symptoms sort of uptick there makes you wonder whether that's just a sort of statistical effort. So we've talked about 2 new mechanisms. And how much longer have I got, Marta? 5 minutes? So I want to talk about one further new mechanism and a different target, and that's targeting the NMDA receptor, which is which is a glutamatergic receptor. And this is of interest because although I've been talking earlier about dopamine and synapses, there's evidence that NMDA receptors and the glutamate system is perhaps a consequence of this synaptic pruning is altered in people with schizophrenia. This is a SPECT study that looked at this, looked at NMDA receptor levels. It was done by Lim Pawlowski quite a few years ago now, showing lower levels in drug-free people with schizophrenia, antipsychotic-free people with schizophrenia. It took quite a few years for us to try and replicate this, but we've now done that. This is a SPECT study that Katie Beck has done at the Institute, using a PET tracer this time, that looked at NMDA receptor availability in schizophrenia. And again, in the drug, first episode, antipsychotic-free patients, lower levels. And actually, you get the hint that there are lower levels across the brain in people with schizophrenia. So this means this is consistent with the idea that there is NMDA receptor hypofunction in the illness. What does that mean for treatment? Well, directly activating NMDA receptors is a bit risky because you might be these are excitatory, you might be overactivating the brain and you can cause fits. But this system relies on cofactors such as glycine. So this is glutamate in blue that binds the receptor. It will only activate the receptor if certain cofactors also bind, and one of those is glycine, which you can see in light blue binding there. So one way of potentially boosting normal, if you like, or physiological NMDA signaling is to block the reuptake of glycine, so there's more glycine around. So you block it, and then that potentially boosts the levels and increases signaling. So that's the theory. A couple of companies have been developing these glycine transporter inhibitors. Roche developed bitopertin, and they tried it in negative symptoms, people with schizophrenia with negative symptoms, and it wasn't successful. and they've discontinued that program as I understand it. But Boehringer Ingelheim have got another program with a different drug that's a glycine transporter inhibitor, and this time they are targeting cognitive symptoms. And they have a very complicated trial that was published a couple of years ago now in the Lancet Psychiatry. It's complicated because they used multiple doses. It's also complicated because it's probably got the longest statistical section of a trial. And here it is. So I want you to read that. Starts there, goes on, and then carries on onto the further page. But the bottom line is they did something that actually I think is quite clever, because quite often when companies do these phase 2 trials, they need to do several doses because they're dose finding. But then, of course, you have a multiple comparisons problem because you've got lots of different arms. And it's a phase 2 trial, so it can't be very big. You don't want to give lots of patients a drug that, we don't know that it works. So what they did here is they said, well, we've got a hypothesis here. We're going to pool all the arms, and we're going to test models based on the fact that there are dose-response relationships in the cognitive outcomes. And the null hypothesis is that there is no dose-response curve. And that allows them to look at all the data from all the arms without making lots of tests. And if you do that, you see this response rate. So 5 out of the 6 different dose-response models they tested were significant. And the overall omnibus test, which is there a dose-response relationship of any sort compared to no response, was significant. So that's encouraging, but it's of course a phase 2 trial, and we need to test that in a further trial. But nevertheless, based on that, the FDA have given it breakthrough designation because it would be the first drug for cognitive impairment in schizophrenia. And they are now testing this in phase 3 trials. I perhaps need to skip over this, and we'll get on to questions. This is about dementia psychosis, where pimavanserin is being tested. But I think I'm going to summarize now by just telling you, I've told you what I think is the most exciting and interesting finding, which is that contrary to what we might think, antipsychotic treatment actually is associated with lower all-cause mortality and lower likelihood of stopping cardiac treatments. We've got longer-acting injectables now available up to twice a year. We need to think more about treatment resistance. It's more common in the patients that we see than the textbooks would tell us, because there's an ascertainment bias. And clozapine initiation is possible in the community. And then on the horizon, we have these new modes of action, which look very interesting. Thank you very much for your attention.
Thank you, Oliver. Time for a few questions.
Thanks. That was fantastic, Oliver. Can I just ask, you do think, though, that it is possible that the people who adhere to antipsychotic medications are also of a different type to those who don't, right? And that this is a very important confounder, right? That's a possibility as well, right?
In terms of the naturalistic data, yes.
Yeah.
I mean, these are naturalistic data, so we don't know. We can't control for all these variables. What is interesting, though, is that if we actually have a look at the data, so who are the patients that are less likely to adhere amongst our patients? Who do you think? What would you say? Just shout out. All of them. Well, I don't know that's true. But is it someone who's taking, if someone's on an oral medication, are they more or less likely, are they the kind of group that are more likely to be adherent compared to someone who's being put on a depot? Do we use depots for people that are adherent?
Yes.
Sometimes, but in general it's the patient that's not able to take their medication reliably. I I think it's not just that they don't want to take it, but many patients struggle, and they end up on depots. That helps them take it regularly. But what they did in these studies is if you actually look at the effects of being on treatment, it's the long-acting injectables and clozapine which did best. And these, if you think about the patients that we think are going to be less adherent in general and the ones that have the more severe illness, those are the groups. So, you know, we can't rule that out, of course, but I think it suggests that this isn't completely driven by that sort of effect, because the ones where you saw the effect most clearly were those patients that have ended up on LAIs and those that are on clozapine.
So, Oliver, diabetes, obesity, metabolic syndrome, cardiovascular risk, with antipsychotics, they don't kill you?
Not at all. That's another area of our research. But what I think is so interesting about these naturalistic data is that in the all things taken together, despite the fact that some of our drugs might increase your risk of diabetes, hypertension, and these other things, all things taken together, we can see that they are not overall killing people. So maybe the fact that you are mentally better, you're less likely to commit suicide, you're better able to engage with physical health care, these things outweigh the consequences of the metabolic effects of antipsychotics. But I'm not saying at all that we should ignore those. We need to also think about choosing the best medication for our patient in front of us and using ones with the lowest risk.
Okay, one last quick question, and then tomorrow we have an entire morning on treatment of psychosis, so don't worry.
Just a question on the aging process and schizophrenia. Do you think there's a biological clock problem, not just cardiac or cancer risk, that the schizophrenia increases the aging process leading to overall mortality?
I think the jury's out about that, but there is this idea that there's a kind of premature aging going on in people with schizophrenia. Perhaps that some of the brain changes as well are linked to that. And you do see this telomere effect, which is associated with aging, and that's greater in people with schizophrenia. I think it's difficult to know whether that's part of the illness or the consequence of the illness at this stage.
Or a consequence of the adverse childhood that many of these people had, which is associated with increased brain age and telomere shortening.
Could be.
So to avoid a fight on this topic, I think we should thank Professor Oliver House